let's talk a bit about non-operative management, because that's going to be the standard for most people. And there's lots of approaches, as I've shown on the slide. You can do no brace and just focus on quads. You can brace for comfort and then focus on quads. You can brace for a specified time to facilitate healing, then focus on quads, and then what sort of brace? Straight leg splint, hinge knee brace, PCL brace. They all go up in expense considerably, so the good PCL braces are quite expensive. But the modern PCL braces are really effective, and I think that's been a big change in how I manage PCLs non-operatively. So years ago I was, look, if you really need a Zimmer splint to let it settle down, fine, but get your knee going, because I think the cost of bracing is that you lose quads, and so much of the emphasis is on having better quads than you ever had before to compensate for any PCL insufficiency. Unless it's just a relatively minor PCL injury, I will tend to use a PCL brace nowadays. You do need to make a judgment sometimes whether people are going to wear it. They are uncomfortable, and there's not much point in people spending the money on a brace if they're not going to wear it, and it needs to be worn pretty much 100% of the time. So typically with a good going PCL injury at 2+ or more, I would put them in a PCL brace, locked in extension, and they stay there for probably a month.
1 month. And then after that 1 month of being locked in extension?
The brace.
Yep. Full range of motion?
90 degrees for another couple of weeks to get going. Their weight bearing is tolerated.
Yep.
But this is talking about a significant injury. We're talking like the 2 to 3+. If it's 1 to 2+, you might not even lock it in extension. I probably still would if I'm going to the trouble of using a PCL brace, 2 weeks extension, 4 weeks coming out of extension. But the key is you don't want the tibia to be sagging backwards and putting strain on this healing PCL. And the only way to really be sure about that is to have the knee in extension. So it is a hassle for the patient. And the other thing to say is you must not be tempted to just re-examine it and see how it's healing. Absolutely no one goes to re-examine the knee until you've made your decision that this is the time the brace is coming off. And then you have a feel of it and go from there.
Just to explain to people who maybe aren't familiar with the PCL brace, but the PCL brace also in literature is referred to as a jack brace, to essentially slide the tibia forward to allow the PCL to heal in not a lengthened position, but a normal physiological position. Is that right? Anatomical position, I should say.
Yeah. So I think you can see that on the image on the right of the slide. If you look at the calf, there's solid strapping around the posterior aspect of the calf. So the brace does have to be fitted firmly, because you're really relying on that firmness of fit to have the brace pushing the tibia forward. This is a much more modern version of the brace compared to the original jack brace, which was way more expensive. I think probably 4 or 5 times what the current braces cost, but also much less comfortable and very poor compliance in terms of patients
wearing them. That was going to be my question,
is
how compliant are people in this brace?
No. Well, you've got to be sure about it first. So I did see a footballer a couple of years ago who can remain unnamed, but I hadn't met him before, but nice guy, club doctors there. I'd sort of made a judgment of what I'd seen on TV and on meeting him. I said, is there any chance you're going to wear this brace? He said, no. I said, that's what I thought, that's fine, let's just get on with your rehab.
So you don't, you just say, do you put them in any, do you even like a limited motion brace, something like that, just to try and get as best as you can, or you just let them go free?
Well, I think just a hinged knee brace probably isn't going to do much because they're not good enough to stop that posterior sag. And in his case, I mean, I knew he wasn't the sort of character to wear a brace, but I had very good results for a long time not using any brace. And so I think you'd need a really good study, and it's just not common enough to be able to study properly to show true benefit. But certainly my clinical impression is that they're better with a brace if you're starting at that 2+ sort of range.
What about in a situation like that, as far as rehab goes, and how aggressive you can go? Obviously, if you're locked in extension, there's not a lot you can do. But with someone who does go, for instance, like in a hinged knee brace, can we go for it as a physio? Like just get them as strong as quickly as possible?
Absolutely. And one of the things that really influenced my thinking about PCLs was a video that a long retired surgeon in Perth showed at a meeting once, and it was grade 3+ laxity, like that laxity we saw before. And the player was a star with that 3+ laxity. And he played with that, and star, small forward, very fast, really a great player. So it did make me realise that there are people who can compensate, and for them they compensate just because of their strength, their coordination, and to slow that down doesn't seem to make any sense. You've still got to respect the effusion and not sort of push them past that, particularly when it comes to running, but I would go for it in terms of strength.
Okay, good point.
As an aside, I did see him in the last couple of years with an osteoarthritic knee. So he paid the price for a chronically unstable PCL.
Obviously there's the body of literature about ACLs and osteoarthritis down the track. I'm not familiar actually whether there's any correlation between PCL laxity or grade 3 PCL deficiency and OA. Are you familiar with any of that?
There is, certainly not documented to anywhere near the same degree, but typically get medial compartment and patellofemoral osteoarthritis. They're the two compartments that get overloaded.